Okay, welcome to level 406, Sociology, Concepts in Health and Ill Health. We're looking at part 2 this week, stigmatization and models of healthcare. So it's broken up into 2 sections, and we'll be focusing on that. Okay, so the objectives and the criteria that we're going to use is 1.3 in your assignment booklet, describe stigmatization and its potential effect upon service users. And then we're going to look at 2.1, evaluate 2 different models of healthcare delivery. And then 2.2, using a case study of your choice, justify a model of healthcare delivery which would be the most appropriate. So you're going to find a case study that explains, that uses a model of healthcare delivery, and then you need to write about why this is an appropriate model, why this is going to be an effective model. I will provide some case studies. You can choose from one of those, but you'll also be able to choose from any piece of research you do that you find that might be relevant. Okay, we're looking here at the causes and consequences of stigma. So Goffman defines stigma as an attribute that is deeply discrediting within a particular interaction. In other words, it's something that's unpleasant or undesirable in a particular context. And through stigma is something that's changed over time. I've given you an example here of cohabitation before marriage, which in the early part of the 19th century had quite a lot of stigma about it. People who were living together but unmarried. But nowadays it's sort of quite accepted practice, and there is no stigma attached to it at all. So as we can see over history, what is frowned upon in maybe one generation might not necessarily be frowned upon in another. It also occurs in a health context where some diseases or conditions are more stigmatized than others, such as things like mental illness, sexually transmitted disease, whereas if you say I'm going to hospital for appendicitis, nobody really says anything. Stigmatization is often a consequence of labelling. There's quite a lot of sociological work around labelling. There are books on it that you can look up if you want. And labelling, again, is the sort of language we use. So it can be due to inequalities, or it can be used due to marginalised groups such as sex workers, transgender people, gay people, etc. And it can come around from fear, not knowing how to deal with people with mental illness, for instance, or being a bit frightened of some of the effects of it. Or it can come around from misinformation. People think that HIV is contagious from toilet seats, as I've given you an example of. So inequalities, fear, misinformation are usually the base of stigma, really. It's often perpetuated by the media, and it can be certain political or religious groups as well. So Goffman wasn't really so bothered about the labelling process. He was more concerned with the consequences of that for the individual. So looking at something known as felt stigma, all of us, including health professionals, perceive certain conditions and disabilities as particularly stigmatizing. And that's why particularly HIV and AIDS, certainly in the 80s, 90s, particularly had a huge stigma attached to it. And it actually, as Goffman said, has the power to spoil someone's identity. So it becomes their identity. The social stigma really is about society's reaction, and that can produce some sort of discriminatory experience. And it's not just the sort of real experience, but it's also the imagined social reaction that somebody can feel, which is known as felt stigma. that, you know, where they actually feel ashamed themselves or embarrassed by their problem or disability. Um, so, you know, it doesn't need somebody else to make them feel stigmatized. They can sort of make themselves feel stigmatized. And it can manifest in feelings of shame, guilt, depression, and sort of behaviors that go along with it, really. Enacted stigma is actually a direct response where someone is treated very clearly less favourably due to this defined characteristic, or it can be indirect where the people are more likely to suffer the effects of different rules or systems that indirectly so stop people getting jobs. Maybe it's not overt, but it's because the rules say you can't. The impact of labelling, it can be really represented as a negative feedback circle, um, which really is a sort of self-fulfilling prophecy, really. So if someone starts off with the issue and the knowledge that there is a stigma attached to it, so if you find it difficult to go out, say because you've got a disability or because of the way you look, maybe you have a skin complaint that some people might find unpleasant and stigmatizing, people will remain withdrawn, stay inside. uh, the more the stigma is reinforced by things that you read, the more you're inclined to stay inside, and it's a sort of a self-fulfilling prophecy, really. So the more withdrawn you come, the more people believe that people with that problem should be withdrawn, and it's quite hard to get out of that circle. And in the case of diagnosing mental illness, the power of the label actually is in the diagnoser, who is generally, say, the psychiatrist. So once you've been diagnosed as mentally ill, labelling theory will say that you actually lose your previous identity, which could have been that of a bank manager or a shop assistant, and now you're a sort of psychiatric patient or a mental health patient, really. And you tend to take on this different persona, and there's a sort of a different type of role expectation. So not an assertive bank manager, but a psychiatric patient who responds to help and advice and guidance from their doctor. So ways to tackle stigma. Challenging stigma is really important. We need to reduce that stigma, because if people have it and they, you know, they don't come and get treatment, or they don't come and get diagnosis because they're ashamed of it, particularly in the case of communicable diseases, people don't get diagnosis and treatment, then transmission will go on. So by having a diagnosis, you know, you can take the advice to, you know, stop sleeping with people in that sense. So on a social level, tackling stigma in marginalised groups helps to widen their participation in society. So instead of all these people being left out or left out on their own, if we are aware of it and we can try and do something about it. So we need to have changes in attitudes, and we need to challenge some of these stigmas positively to change those attitudes. And that should be able to, these changing of attitudes should be reduce that felt stigma that people maybe not starting to think of themselves as a psychiatric patient rather than somebody else. And there are a variety of strategies. One of them is legislation. You can actually outlaw certain things, certain types of enacted stigma, such as abusive behaviour or denial of rights on the basis of a particular characteristic. Hence the UK's Equality Act 2010. There's a very clear legal framework for safeguarding people with the following protected characteristics: as age, disability, gender reassignment, race, religion or belief, sex, sexual orientation, marriage and civil partnership, pregnancy and maternity. So anybody who has one of those characteristics cannot be discriminated against, and it is against the law. The advantage of actually having legislation is there is no question about what's acceptable, and it can also empower individuals to speak up. Of course, the main limitation is although it might change behaviour because there's a consequence to it, you will be fined, you could get a criminal record. It doesn't necessarily change the attitudes. So some people might just go along with the behaviour because they don't want to get in trouble with the law, but it doesn't mean to say they feel differently about the person. They're just, doing what has to be done. Education. This could include public information campaigns to raise awareness of illness and challenge misconception and stereotypes. So, um, you know, um, television campaigns, television adverts have been really, really effective in reducing stigma by improving public attitudes. Although, strangely enough, a piece of research showed that although with some of the big campaigns, such as the Time to Change campaign, which we talk about here, which is aiming to raise awareness about mental health, that ran for a few years, and the research showed that the attitudes of people improved, but their knowledge about mental health didn't improve. So they didn't retain some of the things that they'd heard, but they didn't know that it was, they did agree it was wrong to stigmatize people with mental health problems, which is quite strange, really. Another approach is language, and again, time to change presentation. It showed how important language is for challenging stigma, and about the language you use about people as well. So thinking about using language that isn't derogatory, not discriminatory, and not using some of these accepted labels. My example here is the term schizophrenic implies that the person, their whole identity is about their schizophrenia. So in fact, maybe if you said a person with schizophrenia, it's a way of sort of identifying someone has that illness, but is another person as well. Public acknowledgement is also really important. It may be that of the problem itself, or of potentially embarrassing or unpleasant symptoms. So, and here again, the Time to Change campaign used quite well-known actors or well-known characters, people who talk very openly about their own mental health experiences. And these anecdotal bits of information we've identified, and more people were able to seek help for themselves or family members because they felt it was more acceptable because famous people had talked about suffering. Now there's lots of issues around that, but the mental health campaigning has been really, really effective. Again, I mentioned here a young woman, Jade Goody, who was a reality TV celebrity from Big Brother. Um, and she died very, very young with cervical cancer because she didn't have screening, and well, she chose not to, and she didn't really act when there were some problems going on. And in her, once she'd been diagnosed as terminal, in her last few months, she was very active on social media, telling people about, how she was stupid and that she, wished she'd had cancer screening, and encouraging lots of other young women to go out and get their smear tests and things like that. And after she actually died, there was a massive increase in cervical screening attendance. It took her death, unfortunately, for people to really catch on because maybe they didn't believe she was really going to die. But when she did die, about the 6 months after that, the cervical screening went up dramatically, and it's always been an area it's been quite difficult to get young people to work to do something in. There's also an issue about treatment. Obviously, treating someone's medical problems so that they go away or that they are improved will, naturally visibly contribute to stigma. So particularly if someone's got a skill condition or a manifestation of mental illness, if they're well and they're taking their medication and it's not manifesting, then it's easier to move past the stigma. There is a bit of concern really about, do people have to change themselves to reduce stigma, even when there's no medical benefits? Talking about cosmetic surgery, example here I've given you is like children with Down syndrome. They have very distinct features, suggesting that you could take cosmetic surgery to change those features. Although I think it would be difficult because they also have an issue with their body shape and stature as well, which would take a lot of doing. However, at first glance, if you could change those features, then would they not suffer from the stigma? And there's a lot of people discussing about that, because the surgery has no medical benefits. It's just, it can have plastic surgery, it can have physical risks as well. And does that feel appropriate to do? Okay, so there's some resources as well, for you to have a look at, and some references too. We're now going to look at models of healthcare delivery, and the different types of healthcare delivery and more modern models. We're not really going to talk about old models. We're just going to be talking about some of the models of healthcare delivery that's been developed now and for the future. So why would we change care delivery? Because we know there's a growing number of people with complex health and social care needs, particularly frail older people, together with continuing tight finances, means that the current models of care are unsustainable. New models of care have needed. And with the right services, many people could avoid unnecessary admissions to hospital or be discharged more quickly. So it's about dealing with delayed discharge, which is an issue for particularly in the UK under the NHS. And it's acknowledging the fact that people live longer as well, and that basically it's costing a lot more money that the country doesn't have. So let's think of some of the new models of healthcare we're going to be looking at. We're going to focus on community preventative approaches, better access to primary care and routine hospital treatments, enhanced community care models, intermediate care models, and initiatives designed to reduce delayed discharges. I'll discuss some of the examples above. They're based on a large piece of work that's been done in Scotland through the NHS in Scotland. And you will have some documents to support this in your extra reading as well. And the Scotland audit was quite useful because they have particular issues around rural communities where they're not all big cities where people, are very close to a general hospital, but there's issues about people living in sort of large rural agricultural areas that can't get to services that well, so therefore you need to be more creative. And also with Scotland, there's lots of little islands off the mainland which are, quite remote really, and how do we have to come up with something more creative to make sure that they get service. Enhanced community care is a multidisciplinary team approach aimed at keeping people at home or in a homely setting. So, and trying to manage crises so that people don't get dragged off into hospital only when it's an absolute necessity, and trying to treat people as much as possible. And if the model is good, they can often discharge from hospital quicker because the environment is good for them. So it's usually a large multidisciplinary team, and any extra social care support is then as well. So the East Lothian Service for the Integrated Care, it's known as ELSI really. It's a whole systems approach. So there's a single point of contact for people who are at risk of being admitted to hospital. So then the agency team will come in and see what they can do to stop it happening really. Another thing is a nurse-led telephone advice system to help older people remain well at home 24 hours a day. They can call up, have a look on case study 5 if you're interested in this. They can call up, and if they have anxieties or if they're feeling unwell, sometimes a nurse-led advice information, you might need to improve your puffer, use that a little bit more, or I'll get your GP to come down to you, those sorts of things. Also, community-based dementia care, because there's been a lot of hospital dementia beds closed, there's an increase. So the money from that has gone to invest in people looking after people more in their own homes. So you'd have staff visiting you in your own home and making sure that you're well, really, or using telehealth to help you survive better in your own home. Okay, intermediate care. This involves time-limited interventions, aims at promoting faster recovery from illness and maintaining independence. So, for example, the Glasgow Reablement Service provides tailored support to people in their own home for up to six weeks. So case study 8 will let you find out more about that. So people will leave hospital and then the relevant amount of care will come in for about 6 weeks. And it could be helping people, maybe they've got out of practice with their cooking, maybe they've got out of practice with sort of doing other home management issues, and they will be there to see what they can do to help. And also to find out, what aids and assistant they could do. So is there equipment they could buy in for them that could make these things a little bit easier? For those who maybe aren't quite fit enough to manage in their own home, there is something known as intermediate care, which is bed-based. So it's known as a step up or a step down from acute hospital, or it could be a step up bed from people who are not managing at home and who come in for assessment and rehabilitation as an alternative to being taken into hospital. So it's a place where we can actually help people rehabilitate, again, relearn skills, but also their medical issues are managed, because they're usually manned by teams of nurses, but also with rehab teams of rehab therapists as well. So both aspects are being managed really. And as I said, this could be used to avoid someone going into hospital if it's something that they could deal with. Again, I think they have about 12 weeks. It can be extended on occasions, but there usually has to have a clear plan focus. So delayed discharge. These approaches aim to increase the understanding of the reasons for the delays and trying to find a way of reducing that. There's quite a few models combine reducing delayed discharge, and to do that it's about enhancing the community support. So you can get people home, but as long as they have quite a complex package of care in the home, and that will tail off as need be. One of the examples here is a Glasgow 72-hour discharge model, and it shows patients who are considered fit for discharge, they need to leave within 72 hours. So the clock is ticking for all the staff, so they need to make sure that they get all the things in place. They give them 72 hours because it gives them a clear goal to work to as well, because otherwise these things can drift, and especially if the nurses say, well, I've got other things to do, but the Mrs. Brown's discharge. But if they know it's got to be done in 72 hours, otherwise there are some sanctions against them, it gives them motivation to actually get it done and make those phone calls so that the care agency is on board and the package has been agreed. Another option is people go into they have a temporary care bed, which is a little bit like the step down bed that we talked about. So they move from hospital to a temporary care bed for about 4 weeks, where they would be assessed, and if there's any rehabilitation process. So very similar to intermediate care, but it might be well done in a respite care bed in a care home. So additionally, there are other approaches. So, for example, more enhanced community support services models. Most of those tend to be targeted towards older people because the statistics are it's older people generally that have the mixed complex needs, the multiple conditions, are frailer, may have dementia tied in along with it, so that they have the most complex needs. However, in one area of Glasgow, they've identified that this sort of service should be available to anybody who may be vulnerable, really. And that includes people with mental health problems, or people who use services frequently, or younger people with complex needs and disabilities. So if you have a look at case study 3, that will give you more detail of some of those approaches. Case study 4 looks at nurse-led approaches that maximise the population's resilience. This is the Buurtzorg model of care from the Netherlands. It's quite well known. You could research that and find out and read a little bit about it. It's the example of nurse-led approaches to delivering health and social care, and that's about helping people deal with stress and deal with the challenges of their condition. So they're focusing on that, and then also, in other words, a lot of that is more preventative work. When someone has a condition, they work with them, in the quiet times before maybe there's a crisis, to make them stronger and help them deal with things when crises happen. There are other health and social care organisations to build people's resilience. The Forth Valley, if you look in case study 5, they've introduced an advice line for you, which enables people to get information. And generally, it's not really about crisis. It's about dealing with things before there's a crisis. Thinking about, what don't I know about? Where do I go if I want this information? So, as I said, each of the case studies that are mentioned here are available for you to read in detail in extra reading. You can choose one of these studies for the basis of your answer. I think there's about 8 case studies there. It's all in one document and it will be in your extra reading. You can choose any one of those to write 2.2, or you might find one from your own research that you feel fits the bill a bit more. That's purely up to you. I'm quite happy to read a different case study. I will tell you a little bit more about that when we actually talk about the assignment, how I want you to show that, how I want you to refer to your case study. Okay, there's another little reference for you. Audit Scotland, that's giving you all the information and the background document to some of the ideas that we've been talking about today.